Good morning, everyone. So as Dr. Black said, I'm going to be talking about the application of stimulated Raman histology to urologic malignancies with human and artificial intelligent assessment. These are my conflicts, which aren't relevant for today. But I have some disclosures, and the disclosures are we're going to be talking about pathology, and I'm not a pathologist. But as a show of hands, who here looks at their own imaging when they're operating on people before, after, or during? So everyone. Okay, great. So this is a prostate biopsy. This is on H&E. It can take, on average, a week, 2 weeks to get results back, and sometimes longer. There's a shortage of pathologists, and there's a shortage of pathology techs, and it puts strain on the system. This is something called stimulated Raman histology, which we'll talk about. This is developed in minutes without requiring any pathologic processing or techs. This is an example of a renal biopsy, showing the glomeruli, showing the tubules. And this is an example of the stimulated Raman histology of the same, showing the same things that can be identified very quickly. So as Dr. Black said, this is where I did my fellowship. This is NYU. So it's along the water. You can see the Empire State behind it. It's a amazing infrastructure. They have basically a super block of like 10 blocks. They have the Tisch, which is kind of the private site. And then they have Bellevue, which is the oldest public hospital in North America, and then they have the VA. So it's a pretty impressive infrastructure. This is where I did my master's. So this is kind of the work which was part of a translational master's. And this was my accommodation. Now, can anyone see an apartment there? So I couldn't when I showed up, but that's actually the entrance to this illustrious estate. And this was my welcoming party when I started. There was no rats in my place, but there was mice, not after the first night though. So we're going to start out and just discuss some problems. This is a T2 weighted MRI showing a PIRADS 5 lesion in the midline of the gland. Now, when we have an MRI like this, we need to identify, if there is cancer and treat it. And we can do a transrectal biopsy, which historically has had a high false negative rate. We can do a transperineal biopsy, which there's some challenges with. And in the end, we might not actually have a diagnosis and be left going, what are we going to do if it comes out benign? So in men with a previous systematic biopsy, the rate of a positive rebiopsies varied. There was as high as 39% from literature. So it's like Groundhog Day. What are you going to do with the patient? Okay, well, let's talk about biopsy again. Now with MR targeted biopsies, we feel like, we've solved this problem, but recent publications are showing that, there still is a significant amount of missed cancer. This was a publication looking at negative targeted biopsies and looking at the prostate and seeing what was there. And so if you have, inflammation in your target, you think, okay, inflammation is a reason. So that makes sense. Hyperplasia, also a reason, ASAP pin, benign glands. But you can also have cancer in adjacent cores that are close. So is the answer that the cancer wasn't in the MRI or that you missed it? So there's another publication looking at false negative biopsies from MR targeted biopsies and repeating the MRI. And what they found is if you repeat the MRI, that 75% still have a PIRADS 4 or 5. And of the patients who get rebiopsied, it's about 65% still have cancer in those PIRADS 3 through 5. So there's still a significant amount of cancer that's missed, and there's difficulties with MR targeted biopsy. And this is done with something called the Artemis system, which uses mechanical registration, which is very accurate. So there's still things to be improved upon. Now, let's say we're talking about a radical prostatectomy. You finish your resection, you think, great, I spared some nerves, there's good urethral length, I'm happy, but there can be positive margins at neurovascular bundles, at the seminal vesicles, the bladder neck, the apex, and other areas. So what do you do then? You close the patient, you wait for your path report, see that there's a margin, and you wait to see what happens. If we look at the literature, this was a publication by Ash Tewari from New York, high volume prostatectomist. This was a review looking at positive margins over the years in a meta-analysis, based on surgical type. And I'm not trying to show this to say open's better than robotic. I'm just making the point that margins are significant in the publications and ongoing, range between 15 and 25%. And obviously that's different for every surgeon, but this is a common problem. Now, this is another publication from Martini et al. And it was looking at the margins and saying which margins are significant or, what pathology is significant. For pathologic stage, there is obviously more margins with higher stage. The same is present for Gleason grade and also for grade group and also for the presence of lymphovascular invasion. Now, the question is, what's considered a significant margin? In this publication, they looked at the the focality of the margin, and the length of the margin. Margins greater than 3 millimeters or multifocal were considered a significant margin and had worse biochemical recurrence. So I think this is a problem, and I think the literature would agree. This was looking at location. So, we've talked about there's multiple locations. We talked about there's multiple lengths, and this was stratifying biochemical recurrence based on location. And it might be a little bit hard to see, but if you look here, does this mouse work? Yeah. So this is by location. This is from your bladder neck. If you have a bladder neck margin, it's a very high risk for recurrence. Next is if it's multifocal. And finally, the rest are kind of lumped in: apical, neurovascular, and apex. So some of those can be artifactual or not have recurrence. Some of this can relate to just pathologic processing, and it's actually not disease still in the patient. So there's techniques looking at frozen sections intraoperatively. This is the NeuroSafe protocol, and it talks about the different ways nerves can be spared. What they did is they did a tight nerve spare for all patients. And then they looked at the frozen section of the margin and did a deeper resection if it was positive. And what they found is they were able to spare more margins, and there was lower margin positivity rate in the end. So I think there's some evidence showing that real-time assessment can be beneficial. So let's start off with the same case that we talked about, and we'll kind of work through it. So for him, you could do a transrectal biopsy, theoretically could miss. You could do a transperineal biopsy, you could miss. I was at NYU, which is a center for focal therapy. So you could do an ablation, or you could do standard of care and do a prostatectomy or radiation. So we talked about the histology. There's significant inter-observer variability with prostate pathology. Even for general urinary pathologists, the kappa is about 0.6, which means it's just better than a flip of a coin if they're going to agree on your Gleason score. If you get a non-general urinary pathologist, it's about 0.4, which is worse than a coin flip. Now, artificial intelligence is being applied to most things, and this was a paper that looked at developing a neural network on H&E, applying it at their own site to assess how well they could assess biopsies for identification of cancer, and then doing a validation set from another center, showing a receiver operator curve with an AUC of 0.986. So artificial intelligence can interpret this, it can do very well, and it can be applied to multiple centers. This was a publication out of MSK. It's called the PAGE AI. It's the first FDA-approved pathologic AI in prostate cancer. And what they did is they essentially did this, but they took it all the way through patent. And they had a PPV of 97% and MPV of 99%. This is good enough for the FDA. So this can be in use to help pathologists identify prostate cancer. So let's talk about stimulated Raman spectroscopy. This is C.V. Raman. He was the one who developed Raman spectroscopy, and he won the Nobel Prize for it in 1929. It uses monochromatic light to excite chemical bonds within a sample, and there's two phases: excitation and detection. Energy gain or loss is characteristics of different tissue bonds, and you can detect it. You can then know what bonds are there, and you can create digital images from it. This was a publication out of Quebec. And what they did is they used stimulated Raman spectroscopy of prostate cancer and benign, and they just took point assessments. Each of these are different wavelengths that are gained or lost, and they correlate to different bonds within the tissue. With this, they were able to see differences in peaks for benign, low-grade, and high-grade prostate cancer. And using a neural network, they were able to have some discrimination between benign and low-grade, benign and high-grade, and low-grade and high-grade prostate cancer. So this can be applied. This is a publication that was looking at stimulated Raman spectroscopy, and they were looking at a wavelength which correlates with cholesterol, and they were able to identify mutations in AKT pathway, which is associated with high-grade prostate cancer. So, different wavelengths can be useful for actually identifying genetic mutations. Now, this is the device that I was using. The technique that I was using is called stimulated Raman histology. Most of the work has come out of NYU and one of the neurosurgeons there. So this is from a neurosurgery paper. The first Nature publication was 2017, and essentially what it showed is that an artificial intelligent neural network can be non-inferior to a pathologist in terms of the interpretation of it for the discrimination of glioma versus non-glioma and tumor versus non-tumor. They then went on to publish another Nature paper where they did a non-inferiority trial and showed that you can identify and differentiate tumor type and tumors present within 2.5 minutes instead of 30 minutes required for frozen section. It was non-inferior in terms of the diagnosis. So this is their most recent publication, just published last month. And what they did is they used the neural network and they built it looking at genetic mutation. And what they found is they could discriminate genetic mutations for the three of the genetic mutations required for glioma versus non-glioma. And they could do this within 2.5 minutes. So they called the neural network deep glioma and achieved an F1 of greater than 96%, between 94 and 96% for identification of these mutations. So you can do this, and they were doing this within 90 seconds. Normally this is requiring, tissue processing and pathologic assessment. So for the creation of this is one of the slides. You take the tissue, you put it on the slide, you put it into the microscope, you hit scan. Depending on what you're looking at, this is a renal biopsy. This is a prostate biopsy. So to visualize a whole biopsy, you generally need about 2 or 3 scanning sections. It takes about 8 to 11 minutes. You get a CH2 and CH3 image. CH2 images correlate with lipids, CH3 RNA, DNA, protein. They then put those overlapped and then do a color overlay, which makes it look similar to H&E staining. Initially, when I started applying this, I'm looking at the neurosurgery specimens saying, oh, they look fantastic. This is what mine looked like. Now I realized that if you ink the margin, it affects the Raman spectroscopy. And this was also done at 10 microns depth. So I had some optimization. When there was no ink and at 10 microns, started to look a little better, but not great. Finally, we found that at 20 microns depth, you can have, the best balance and, good tissue visualization. Now, initially the slides that we had, essentially it's a circular or square viewing platform. It's great for neurospecimens. You put the brain tumor on it, you squish it, you image it. Hard for me to get a prostate biopsy without cutting it into pieces. So I created this circular kind of design, and that would take usually about 18 to 20 minutes to image a whole biopsy. Then creating it into vertically sectioned images, I was able to get down to 8 to 11 minutes per biopsy. So for the basis of the study, most of it was done ex vivo to start. Took a prostatectomy specimen, biopsied it, put it onto the microscope slide, into the microscope, scanned it. You got the SRH, which you can see here, and then you got the tissue is viable after. So you can send it down to pathology, H&E stain, cut it into section, and do routine pathologic processing, including immunohistochemistry. For everything in this study, we had at least 2 pathology agreement on Gleason score. So at least 2 on the H&E. Some of this required 3 as well. So we'll talk about that. Now we're looking at concordance. How well does this match with H&E? And so we did a power assessment, and 32 patients was expected to give an accuracy of 90%, an alpha of 0.05, and a statistical power of 90%. This is an example of stimulated Raman histology of a prostate biopsy. Now, when I first show this to pathologists, they're like, what is this? This doesn't make sense, because this is actually fat. You can see fat droplets here. This is things that can be lost on tissue processing. You can actually see the capsule of the prostate here, and you see glands infiltrating right to the capsule. This was a biopsy that I took from a prostatectomy patient, showing cancer very close to the margin. You can see a nerve here, and you can see perineural invasion here. This is actually cells and glands that are extruded. This is all lost in tissue processing. The pathologist that I was showing had never seen this before, because this is lost as you're going through the steps of trying to visualize it with standard of care. So I created a training and testing cohort. In neurosurgery, it looked like 16 biopsies was enough to kind of train the pathologist's eye. And then I created a testing cohort. Testing cohort, I tried to mimic MRI targeted biopsies. So I had a mix of benign and malignant pathology. For the training cohort, the pathologists were given the H&E and the SRH, and they were allowed to train their eye. They were given as much time as they'd like. Then I gave them a testing cohort where I gave them 32 biopsies, and I asked them to grade it like they normally would for their prostate cancer diagnosis. Now, I found a high sensitivity, an average of 95.6%, but a poor specificity, 58.3%. And that related to 2 pathologists who had difficulties discriminating benign from malignant, and were calling most things malignant. After that, I let the pathologists confer together, and I let them work together, 4 of them, having a discussion. What do you think? The sensitivity remained the same, but the specificity came up to 100%. So to me, this said this is a technique that requires more learning, more training, but there's promise that it can be interpreted. And I'll go through this a little quicker just because this is the same. This is just showing the individual pathologists, and their combined accuracy, looking at it, was 65.6% for benign. But if you look at their H&E, it was 100%. So it's not saying that these aren't pathologists that know what they're doing. It's a new technique. It takes longer to train them than 16 biopsies. 16 was used because that's what they initially used in neurosurgery. So if we compare that accuracy, 65.6% for benign, if we look at malignant, and this is GG1 through 5, the combined accuracy was 95.7%, so much better, and clinically significant GG2 through 5, 96%. So their accuracy was better for the malignant when it was only malignant specimens present. And if you look at their accuracy as a whole, for all of them, is over 87%. Just some struggling with the benign to start. When we looked at the concordance, this is for concordance of agreement between SRH and pathology. The first two pathologists had very good, near or excellent concordance. The other two pathologists was poor, and once again, that relates to the specificity, which gave an average concordance for the group of 0.5. So that's about a flip of a coin. But if we look at their identification of clinically significant cancer, it was the same. But after the consensus conference, near perfect. So they are, getting better with time. But finally, if you look at their ability to tell Gleason score, it was poor as their mean individually, but as a group, they were 0.47. Once again, agreement of pathologists, non-general urinary pathologists for H&E in publication, 0.5-ish. So, getting close. Now, these are some of the challenging cases. So, if you look here, there's no pathologist here, but what I'm going to do is point out this is cancer. And this is pattern 4, and this is ill-formed glands. These are small ill-formed glands. So it's quite challenging to identify that. On SRH, they're pretty much invisible. So what it showed is, low volume, small different subtypes of cancer. It might be very challenging for humans or artificial intelligence to identify it. This is another one. This is benign muscle hypertrophy. You can see on the H&E, this is one that almost all the pathologists called cancer, just because of the look of it. So there's challenges to overcome. Now, next I want to talk about SRH and artificial intelligence. So it's previously been done in neuro, and I developed a similar protocol. Took 303 biopsies that were visualized with SRH, which had two pathologists agreement on for the Gleason score on the H&E, then annotated them. So this is gland level annotation, outlining all of the glands. Then developed a model through collaboration, an Inception ResNet 2 neural network, and using a cluster analysis. The reason why we did this is I'm not, at least for now, interested in identifying one cancer gland. If we're trying to discriminate cancer, non-cancer, one gland, that's for a pathologist. I wanted a small area equivalent to about 5 glands. If there's about 5 glands, that's kind of your discrimination between ASAP and prostate cancer. And then we created a biopsy test set. Biopsy test sets can be from ex vivo prostate biopsy, or we started to do it in vivo during patients who were under anesthetic for a mapping of their cancer during ablation. If the neural network said that there was a greater than 89% probability of cancer, we said that contained cancer, whereas below that it was benign. We created the testing set. So the testing set has a lot of benign, but also a varying amount of malignancy. And for the testing set, similar distribution. And that was 113 of mix of ex vivo and in vivo biopsies. So to make the SRH, you need the CH2 and CH3 with a color overlay, and that's for the visual eye. But for artificial intelligence, you can use the CH2, you can use the CH3, or you can actually start skipping lines. So you can skip half the lines, then increase the size of the lines that are left to make it look like a similar image. And we tested also the assessment with that. Now we're scanning at 2 to 3 scans per biopsy. So it's 8 to 11 minutes for visual assessment in SRH, but it's 2 to 2.75 minutes for if AI is doing this faster. Now, if we're scanning a biopsy for the human eye, if we do the first scan and we identify cancer, in one of the studies I'll show you later, the mean time to diagnose cancer is 3.5 minutes. If we use the AI, a whole section can be in 1 minute. So you can, if you have a lot of cancer or you scan the first part that includes cancer first, you can have a diagnosis in 1 minute. So after the built it, then tested it. And so the training patches represent, so for all the biopsies, 96% of the biopsy patches were used for training the network. 4% were left out, and that was used as a validation set. Now it's kind of cheating because the AI has already seen the patient's biopsy, so there can be obviously similarities there, but that was the start. And on the training patches, the accuracy was 99.6%. On the validation patches, the accuracy was 98%. Now, ex vivo prostate biopsies were what the model learned on. So it learned on prostatectomies taken out, it's fresh, take the biopsy, and then assess that. The network hadn't seen any of these biopsies, and the accuracy for the identification of prostate cancer is 98.3%. Now, there's also in vivo biopsies. These were during cryotherapy, partial gland ablation of prostate cancer. The accuracy in this, and these aren't all targeted biopsies. Some of them are essentially margin assessments around our treatment zones. The accuracy was 94.4%. Looking at the combined ex vivo and in vivo sensitivity, 96% for prostate cancer, 96% specificity with an accuracy of 96.5%. So I can tell this on biopsies that were done ex vivo, also in vivo, and these were all done during the case. So we'll talk a little bit about that later. Next, we assess the forward scan speed. So this is getting the whole biopsy interpreted in 2 to 2.75 minutes. We saw that on the ex vivo biopsies, 96% accuracy, in vivo, 94%, sensitivity, 94%, specificity, 96%, and the accuracy, 95.6%. So it can do it fast and it can do it accurate. So let's talk about clinical application. We talked about, so clinical application can be, for treatment or for diagnosis. This microscope, the one that I was using, was located in the hospital around the OR. So all the biopsies are done in clinic. So I couldn't do it during diagnostic biopsies the way that they're normally done. But we could start applying it during focal therapy. And so this is an FDA approved device. So we can just consent patients that we're going to be doing margin assessments and then modifying treatment. So what we did is we took a biopsy from the MRI identified lesion. Now this is all done under ultrasound registration. So you have to think, when we are doing a biopsy for prostate cancer, you have your registration, which can be cognitive, software, MRI. But when you're doing it diagnostically, a lot of it's done software. I mean, this software is telling you where to biopsy. A negative biopsy means you miss the whole cancer. When you're doing cryoablation, it's done cognitively. So you're using your brain to assess on the MRI and the ultrasound where the cancer is, and then create a treatment plan to ablate the cancer. In addition to just ablating the cancer, there's whole mount studies that have shown there's about a centimeter of margin that you need to ablate. So you have multiple possible errors where you can leave cancer behind. And one of the big limitations of focal therapy has been the recurrence rate, which ranges between 20% at 6 months to 50% at 2 years. It's very different depending on the modality and who's doing it. So for this, what we did is we took a biopsy from where we thought the cancer was. And you can see this patient here. This was the first patient that we did this on. You can see GG2 prostate cancer. So, we hit the cancer. Next, we took biopsies from a centimeter lateral to the tumor margin, and then we started to ablate the tumor. So we placed 2 cryotherapy probes, formed a freeze cycle. We then decided to just take 1 biopsy lateral to the treatment zone. So obviously, there's a significant margin that wasn't sampled, but we just wanted to see what happened. So we sampled it. This is benign, so that's great. Sampled this one, should be benign, more cancer. That gave us the ability to put in another probe, perform a freeze, and then assess it again, which then we had what was a negative biopsy. We concluded the study there. So, this is a possible application real time. This was all done. This didn't increase operative times. It was done while the patient was asleep and the procedure was going. So looking at, we ended up recruiting 12 patients for this. This is essentially pilot data. It was my first year was research, my second year was clinical. So this is in between ORs, days where I wasn't operating. And in 12 patients, we were able to identify 6 biopsies that had cancer 1 centimeter lateral to the margins. That's your cognitive registration is off because, from whole mount studies, we know it should be within a centimeter of that MRI identified lesion. Now, after we performed the freeze, we were identified 2 biopsies where cancer was lateral to that treatment zone. In the end, we modified 25% of patients' treatment because of underestimation of where the cancer was. Now, being that we'd done some looking at this to build everything, we started actually doing, we're tailoring treatment to it. So assessed the surgical team's diagnostic accuracy and results. 100% sensitivity, so didn't miss any cancer. 97.4% specificity. Now, the 1 biopsy that was identified as cancer, it required IHC for the pathologist to tell that it wasn't grade group 1 prostate cancer. If a pathologist needs IHC, pretty good. And an accuracy of 98%. Go ahead.
One question. How did he assess that you did not miss any tumor?
Yeah, so this is so this is looking at the histology. So the biopsy is taken from SRH, then sent to pathology, and that was used as the ground truth. So it's 2 pathologist agreement on the H&E. Now, in terms of actually missing cancer in the patient, totally different discussion. Still have to review those results to see biochemical recurrence, but not biochemical. To look for MRI, recurrence positive on repeat biopsies. Don't have the oncologic results. This is all just based on the actual pathology. So what was sent to the pathologist and compared side by side, that was these results. So this is the surgical team interpretation. Well, let's look at the AI results. Sensitivity, 88.2%. Not as good, but pretty good. Specificity, 97%, with a diagnostic accuracy of 94%. That's at the full scan speed, 8 to 11 minutes. Now, if we look at the accuracy of a 4-time scan speed, 94%. So that's in 2 to 2.75 minutes for the entire biopsy. And finally, looking at the network's ability to identify, clinically significant cancer, 100% sensitivity, 96.6% specificity, and an accuracy of 97.2%. The biopsies that were missed, 1 millimeter to 1.5 millimeters of GG1 prostate cancer, which you can argue it's not clinically significant. So what about standard of care? If you decided to do a prostatectomy on this patient, this location, not bad. You'd say, I could probably spare the nerves. I'm not too worried about that location for a grade group 2 prostate cancer. What happens if it's posterior, right along the capsule? Well, what we decided to do was start assessing this during route. And surgeons were told to do your usual surgery, and then after, take 3 to 5 millimeter samples from the neurovascular bundles or areas of concern. And so what we did was we took biopsies, we started looking at it real time. This is a biopsy. You can see there's prostate cancer in that surgical margin. That's benign, and there's more cancer. Difficulty here, for at least my interpretation, was how the nerves look on end. When you have a nerve like this, that's easy to tell it's a nerve and not cancer. When the nerve's actually on end, it looks very similar to glandular morphology. So we recruited 22 participants for this, and there was a mix of grade groups. And 13, so most of the patients were clinical T2. Now, we performed a total of 121 margin assessments with a mean of 5.5 per patient and a time per assessment of 7.5 minutes. Now, if you compare that to the frozen section analysis, in some studies, it's 30 minutes for a frozen section. So it's much quicker. Looking at SRH's ability to, yeah.
So how are you identifying the margin? Are you just picking something off the stay side or off the prostate side?
Stay side. So this is in the patient. So we just took little sample. This is kind of like a NeuroSafe protocol. Took small samples, 3 to 5 millimeters.
NeuroSafe takes the actual prostate.
Yeah. So but the NeuroSafe is doing a tight assessment on everyone and then assessing it. This was actually from the patient, just small 3 to 5 millimeter samples. So this would be like doing a frozen section from the actual patient of area that you're concerned. So on SRH, we identified 5 biopsies intraoperatively where there was still cancer in the patient. And there was found to be 6 on H&E. So we missed one with the SRH. Now, looking at the margin positivity by pathologic stage, it was a pretty high risk cohort. And there was 7 total that were positive. 1 came from T3A. This has kind of moved down, that the bubble should be for 6 were from T3B. So more advanced cancer. All right, now looking at the surgical team interpretation, this is intra-op interpretation, sensitivity 83%, specificity 98.3%, which gave an NPV of 99% and an accuracy of 95.5%. This is done all intraoperatively while the patient's under anesthetic.
Is this you or is this similar to me? When you say surgical team?
Yeah, it's me. Yeah.
It's not just the novice surgical.
Yeah, you know what? I think, so right now, I don't have the AI for this. I did test the AI after. The AI was only trained on biopsies. Now, I have 121 margins. And if you think of a biopsy, it's, what 1-ish millimeters by 2 centimeters. These margins are like 5 millimeters by 5 millimeters. So there's a ton of data in it. So I have 121 margin assessments with a ton of data. I've just finished annotating them for training. So I'm going to be assessing how well it performs retrospectively and then hopefully prospectively. So yeah, for now, I mean, I've looked at a bunch of these and I kind of know what I'm looking for. It does take some training, but in the end, the goal would be to where AI can do it and do it real time. Okay, so in summary, prostate SRH can be accurately interpreted by pathologists and surgical teams. Procedural SRH can aid in the identification of positive surgical margins during prostatectomy and prostate cancer mapping during prostate partial gland cryosurgical ablation. AI shows equivalent diagnostic capabilities to human interpretation of SRH, and AI interpretation shows improved speed of diagnosis, identifying cancer in some biopsies within 1 minute. Well, I had a little extra time, and so I started looking at renal biopsies as well. And so I started looking at ex vivo renal biopsies. And I think everyone here knows if you do a renal biopsy, a lot of them come out non-diagnostic. In the literature, the rates lower. It's only about 25%, though in some patients can be up to 45% if it's a difficult biopsy. So once again, it's like Groundhog Day. What do we do? Well, we should just take it out or we can watch it. So this was the first kind of assessment I did. And I was thinking more in terms of transplant because, that's where, or benign renal disease. And what I want to do is just look and see, can you see that the architecture? And here's an example. Routinely, and not even at all centers, you take a renal biopsy and someone will look under a light microscope and look for glomeruli. Now, this is a really obvious example because anecdotally, there's lots of examples of, I took a biopsy, a benign renal pathologist, their job is just to look at this, says there's no glomeruli. They then take another biopsy, look in the end, there was like 10 glomeruli. So it's challenging even for experts, and it's not done at all centers just because of the resources required. They have to be on site because it's light microscopy. This is SRH. You can see here, you can see tubules, you can see glomeruli, gives you nice architecture. Immediately, pathologists, when they look at this, are much less upset about the look because you can see the gross morphology quite easily. Now, what we decided to do was we took ex vivo renal masses, biopsied them, put them into the microscope, and then started imaging it to see what the images look like. So let's say you have a biopsy. Let's say this is your patient. You send them for a biopsy. It's like a 1.5 centimeter mass. They're old. You're not sure you really want to do anything, or they have comorbidities. You're wondering of the significance of this mass to the patient. You biopsy it. Comes out like this. Well, that's benign. So that would be non-diagnostic. What happens if it comes like this? Well, that's clear cell, papillary, chromophobe, renal medullary. I didn't put the oncocytoma in this, but it does visualize oncocytoma as well. So this can be great in terms of identifying that you have enough tissue to make a diagnosis.
So Miles, when is it non-diagnostic, or could it just be benign?
Well, a small renal mass should always have some pathology, right? It's not like a hypertrophy of a benign tubule. It's an oncocytoma, it's an AML. Like, it is a mass that should have pathology that can be identified, and you should be told that, this is what it is. That's a great thing compared to prostate. In prostate, it could just be BPH. It could be inflammation. In renal, we know that there's some pathology. So if you get something that says benign renal tissue, they missed the mass, or from tissue characteristics, it fell apart while they were trying to get over to pathology. So you should have something. So what we did is we looked at this, compared it from SRH to H&E. Now, one thing about H&E, and this is one thing I learned, obviously I spent a lot of time around the pathologist in the pathology lab. A lot of pathologic interpretation is actually looking at artifacts of what happens when you process it, clear cell. So you lost that cytoplasm, so it looks clear. So there are challenges between identifying subtypes, and this was just done in terms of describing the differences. And the classic things that you see for different subtypes are difficult to identify with SRH, but there are things that can be identified. Sometimes you get, let's say with clear cell, you might see changes in the capillary network, or the amount of cells and the arrangement of the cells around the network. So right now, don't know if we can tell the difference in real time, but there does appear to be some differences. So in summary, renal SRH can be used to efficiently and accurately determine the adequacy of a renal biopsy. So I just want to finish and say that SRH is a new technique which can bring pathology into the surgical suite. SRH can be interpreted by pathologists, surgical teams, and artificial intelligence for the identification of prostate cancer. The interpretation of SRH can influence prostate cancer treatment, and the AI can identify prostate cancer in many biopsies within a minute. And at UBC, we've obtained funding for the first SRH microscope in Canada. It's called the NEO, and hopefully will be arriving shortly. Thank you. I'd like to thank Dr. Taneja and the NYU urologic oncologist for helping me with specimens and my training. Dr. Oringer, so he's the neurosurgeon who's kind of been the big lead on this kind of worldwide. Dr. Dang, he's the pathologist who let me bother him incessantly to try and get this done. And then the company for helping with development of the neural network.